This is Ethics Lesson 2. We're going to be talking about competence in here. We're going to be talking about the areas and the limits, asking for assistance, dual diagnosis, the responsibilities of patients and professionals. We're also going to be talking about professional development. So one of the most common and the most difficult problems that's faced almost daily is the question of individual competence. Not everybody is able to do everything, but what are those limits? They continue to elude us no matter how hard we work at policies and definitions, because obviously they're going to change with the setting and the time and our individual talents and also our personalities. So many skills need to be learned. Others perhaps never can be. A hard look at some of these problems may help us to avoid a number of the pitfalls and make us more aware of and comfortable with what our limitations are. And we can try for wisdom to see the difference between what to accept as within our abilities and what to refuse as beyond our present abilities. So the environment in which counseling is done and the availability of supporting professionals like the clergy or psychologists or other addiction counselors, this creates different demands and expectations for both the patient and the counselor. And in many parts of the country, there still may be no legal constraint on alcoholism counselors, whether they're credentialed or not, and that prevents them from setting up a private practice. The counselor who's been working in a clinic as part of a treatment team and has had regular supervision, immediate access to a physician in case of an emergency, a skilled social worker at hand, and other help that's easily available, they may now try to fulfill all of these functions alone. And the counselor is the same, the patient's the same, but the situation is very different. So one person who was providing this form of treatment was very hurt when they were questioned, "Don't you trust me?" she said. "I'm seeing Dr. Brown every week and I'm paying him for supervision." And she was, but the answer is still no. We don't trust you. To trust her genuine good intentions is easy. To be comfortable about the situation is another matter altogether. Private practice is going to require a far greater competence and professional training than working in a team under supervision, according to the ethical codes of all the professions. Along with this specialized training in chemical dependency counseling, a master's degree should be the minimum legal requirement for private practice. And failure to provide an adequate follow-up plan upon discharge seems an obvious breach of ethical practice. But more subtle problems arise as patients get further into recovery. And a lot of the counselors are really excellent at breaking down a new patient's denial and helping the patient accept that they are chemically dependent, that abstinence must be the goal, and that recovery is possible. The patient is going to move smoothly into an appropriate mutual help group, and they're going to learn new coping skills. And then they begin attending a therapy group, and they become increasingly confident and comfortable with living sober. And it seems like a success story, but then 6 months later, things are far from rosy. The tasks of early sobriety are quite different from those that are faced later on. And when that novelty is worn off, and when abstinence alone has failed to rejuvenate that mediocre marriage, or when a major decision about a job change needs to be made, or when parenting an upset adolescent seems hardly worth the effort, or when sexual functioning has still not been fully restored, and when, in general, the rewards of sobriety seem like a broken promise, the patient and the counselor might discover that they are no longer right for each other. And the treatment and the guidance that's needed now may call for a different set of skills. The patient's the same, the counselor's the same, the treatment setting's the same, but the problem is different. And the competence needed now is not necessarily greater, but it's just not the same. And sometimes it should be obvious that counselors are being asked to undertake problems that are beyond their abilities. And it's important that after years of neglect, these family systems in alcoholic families are finally receiving attention. But does it make sense to ask a counselor whose only expertise at marriage counseling might be derived from the misery of their own three failed marriages? Or a counselor who visited Al Anon a few times to assume the role of the family therapist? This happens too frequently, and the result is that the needs of the family are sacrificed on the altar of getting the addicted family member into recovery, no matter what the price. And sometimes counselors deal with their personal prejudices and their other limitations by just simply denying that the problem exists in the first place. One counselor, when asked about his management of a client's severe anxiety over failure in sexual performance, was eager to explain that it was too early in sobriety to discuss the problem, and that time and physical healing would automatically resolve the difficulty. End of problem, right? At least for that therapist. Another counselor was asked how many gay and lesbian clients she had seen in a clinic in the last year and how many of her colleagues were homosexual. The answer was one patient, no fellow staff. At least 20% of both groups were easily identified by a sophisticated observer as homosexual. But this counselor denied any need for any additional training in how to identify or work with this population. Ignorance not only makes a good chaperone, it works well to keep a variety of problems at bay. Discomfort with other races and ethnic groups, problems relating to the adolescent or to the elderly woman with the weak hearing aid battery, uneasiness with the retarded, the handicapped, the cross-addicted, the patient who also has cancer or AIDS. What about anger with someone who's merely ugly or disagreeable, or who repeatedly relapses after getting us to believe that this time we have worked the miracle? No one's comfortable with every group, or sensitive to, or even informed about its needs. At best, we need to be aware of what we can do and what we cannot do, and assume responsibility for getting patients that we can't help into the best situation that's available for their particular needs. The real failure is denying that there's a problem, thus leaving the problem unresolved, and that prevents patients from getting the help that they may get from somewhere else. And part of our professional obligation of restricting practice to one's area of training and competence is the importance of making referrals to other agencies for services one cannot or chooses not to offer. The temptation is to want to handle everything alone. A real expert knows when to ask for help and where to get it. AA itself has a very long and strong tradition of cooperation without affiliation with various professions. One social worker remarked on the irony that while chemical dependency workers often complain that social workers do not refer to them, she had considerable expertise in handling problems that addiction counselors were untrained for. Yet she never got a referral from them. Clergy and psychotherapists in the past may have left a bad taste in the recovering person's mouth. But recovered people now acting as counselors need to identify non-addiction issues and remember that referral is a two-way street. One recent research paper shows that 91% of patients complain that their spiritual needs are not adequately met in treatment centers. And a 1983 three-year study of 441 patients called the spiritual the most neglected part of therapy. This implies an ethical obligation on the part of those that are responsible for treatment. But too often, we get the emphasis on addiction to alcohol or other drugs as the primary problem, has created the impression that it is the only problem. Mere removal of the drug doesn't mean family or other problems are resolved. We know that with sobriety, a host of new problems that were masked or ignored during drug use often surface. So these new problems may need medical or legal, spiritual, marital, vocational, financial, or other types of help. So one loyal AA member, now a competent professional, remarked at a national meeting of AA members working as addiction professionals that if a person had appendicitis, we would not suggest go to more meetings. And it hardly needs saying that both a non-physician counselor and an AA member go beyond their competence when they advise an addict not to take medicine that's prescribed by a physician. This is practicing medicine without a license, and it may amount to murder if the addict dies as a result. We're not speaking here of the addictive psychoactive drugs like amphetamines or barbiturates or opiates or benzodiazepines, which those do carry that inherent danger of substitute addiction, or what we call synergism, that multiplying effect. And these are often incorrectly used, whether by prescription or not, to treat addiction. And use of these drugs should always be questioned. We're speaking of other legitimate drugs here, which may be a necessity for an addict who may have another medical or psychiatric condition, um, like digitalis for a heart patient, or insulin, or oral hypoglycemic for a diabetic, or Dilaudid for an epileptic, or lithium for some sort of manic depressive disorder. The same applies to disulfiram or antabuse, or naltrexone, which is Trexin, which are not psychoactive drugs or a substitute for alcohol or opiates, and these could be life-saving for some alcoholics or addicts. So dual diagnosis, not a dual addiction to alcohol or another drug, but the occurrence of both addiction and a mental illness in the same patient, has in the last decade become increasingly recognized. So this presents no really new ethical problems, but it alerts all to the obligation that both addiction and mental health professionals have to cooperate and respect each other's area of competence and just not go beyond their own. Addiction workers have really struggled to get addiction to alcohol or other drugs recognized as a primary illness, not merely the symptom of just some mental disorder. You can't do psychotherapy with a toxic brain, and that statement right there became almost a battle cry. There was a really great effort to determine which came first and which should be treated first. It's kind of the chicken or the egg theory here. But it's not our place to lay down rules about diagnosis or treatment. But we all have an ethical duty to lay aside territorial jealousies, to admit our limitations, and just to cooperate for the good of the patient. Although a licensed psychologist admits that most psychologists really don't understand addiction, and even a well-trained addiction counselor is probably generally not competent to diagnose and treat a mental health disorder. Inappropriate response to a suicide threat can have legal as well as human and ethical implications. So there seems to be this greater proportion now of counselors who have college degrees and training in fields other than addiction like psychology. And given the current emphasis on the dual diagnosis, this seems like a clear plus, but there are some dangers out there. For one, these newcomers and other people might be tempted to look down on the older counselors whose qualifications are rooted in recovery and AA and non-degree counselor training programs. And some states have proposed legislation that would require counselors to possess certain academic degrees. And the reason appears to be primarily economic and political, since these new requirements don't insist on any specific expertise in chemical dependency. One southern state, for example, specifically exempts the clergy from any need to demonstrate any understanding of addiction. So discounting the experience of the older counselors would be both unprofessional, and it would be a great loss to the newcomers themselves. Not only are these veterans the one who built the profession in the first place, but there is much accumulated wisdom in their background and their experience, and in AA's conference approved literature. Again, too much emphasis on psychology can cause professionals to miss the basic neurophysiology which underlies addiction, while too much emphasis on degrees can cause administrators to undervalue addiction specific training and experience. But on the other hand, counselors of the old school are too prone to take kind of a dog in the manger attitude toward the very real contributions that psychology can make to enhance this long-term effectiveness of their efforts. Recent work on relapse prevention is fairly well known, but other approaches have been avoided through either ignorance or prejudice because these approaches are linked to controlled drinking rather than total abstinence as a goal for recovering persons. This reluctance to be open to the new approach is both unprofessional and unethical because it robs the patients of optimum chances of recovery. And ignorance about the legal implications of certain actions and court procedures, or how to write a pre-sentence recommendation, and of how to cooperate with probation and parole officers, not only can make a counselor ineffective or harmful, but can also discredit the profession by making its members seem inept. People can actually go to jail if we don't know what we're doing. And likewise, it's deplorable the tendency among some counselors to act as enablers by helping addicts dodge legal responsibility for their actions, or to generalize and automatically see every person arrested for drunk driving as an alcoholic. The Georgia DUI intervention program says that less than half of the people that come to us for evaluations are going to have a substance use disorder or an alcohol use disorder. Some counselors seem to forget that calling chemical dependency a disease does not mean throwing all morality or moral responsibility out the window. The psychologist Lewis M. Andrews, he's a PhD, has vividly exposed the myth of value-free therapy and depicts the rebirth of ethical values in counseling. The patient may not be responsible for being chemically dependent, but still has an obligation to do something about it. And since the very nature of the illness diminishes freedom of choice, the initial obligation may be to listen to others with openness, to accept help, and to use the available means to avoid using alcohol or other drugs. And one may still have some responsibility for the consequences of active addiction, although here, guilt must not be confused with regret. The counselor may have to point out that people may be legally responsible for crimes committed under the influence, even in a blackout, although the degree of guilt is a matter for courts to decide based on the evidence. At times, the counselor may have an ethical obligation to confront the patient about responsibility for the consequences of addiction, such as the abuse of a spouse or child. One recovered former child abuser told his counselor, "My last few counselors spent hours on understanding why I act that way, but you're the first one who ever told me not to do it." The basic principle of not attempting to work beyond one's ability applies to institutions as well as to individuals. So, for instance, there is a kind of a current trend among well-regarded adult treatment programs to claim that they have a treatment program for adolescents when they've neither acquired the specially trained staff necessary nor have they developed the specific types of programs that adolescents need. And this is unethical. The same holds true for any unqualified facility that treats a significant number of minority groups, like African Americans or Jews or gay men or lesbians, American Indians, and so on. Admitting the occasional one or two without added programs or staff may be justified, but admitting a large number or advertising competence in handling special interest groups leads to an obligation to keep the implied promise and provide appropriate treatment. Some treatment facilities, usually residential, that were initially designed to treat chemical dependency have moved really far beyond their initial mandate. First, they've added programs for immediate family and significant others of the patients, and then they move into treatment of adult children of alcoholics. Next comes gambling and eating disorders. And then they add on codependency, which is defined as coming from virtually any kind of dysfunctional family. And then sexual addiction is being included. Most of these conditions are regarded as quote unquote addictions of sorts, and introduction to 12-step programs is seen as part of the cure. And while these activities may indeed have some people, there is much room for questions. Is the motive largely financial? The prices charged tend to be very high, while evidence of their effectiveness is largely anecdotal. More importantly, the counselor working in such a facility, they're likely to be faced with patients whose problems are well beyond their own experience or training. And then lastly, competence in a rapidly changing and highly complex field demands constant upgrading of skills and knowledge. Most professions are going to require continuing education as a condition for renewing a license or a certification. In-service training is usually not acceptable to meet these minimum requirements, and that forces one to get out of that narrow confine of that one place of employment and to get some fresh viewpoints. Most conscientious workers, aware that professional development is their personal responsibility, really go far beyond the usual minimum requirements in keeping abreast of any new developments in the field. Regular reading of professional journals and new books, attendance at conventions and workshops, and taking additional courses are some ways to keep up. Those who feel that they have nothing else to learn once they have qualified for an initial credential are a danger to the profession and to the patients. One could ask, when's the last time I read a research paper or attended a conference that was not a requirement for renewal of my credentials? Since going beyond one's competence is forbidden by all ethical codes, we must constantly stay alert to learn more about our limitations and be able to recognize when it is in the best interest of the patients to release them or refer them somewhere else. And these limitations may stem from a lack of training or experience, unfamiliarity with the area in which the problem is falling, the difficulty or the complexity of the case, or maybe even interpersonal problems between the patient and the counselor. Problem solving in any of these areas may be aided by continuing education and having a clinical supervisor, and that can prevent really serious problems.